The broadcast is now starting. All attendees are in listen-only mode.
Happy Tuesday, everyone, and welcome to Dimensional Insights webinar, How Dashboards and Data Are Being Used on the Front Lines of COVID-19. My name is Kathy Susich. I'm Director of Healthcare Marketing at Dimensional Insight, and I'll be moderating today. In this session, we'll take a look at some of the best practices of organizations that have brought data to the front lines, and we'll also look at the types of data they are pushing out to their clinicians and administrators. We will share experiences and ideas on how to leverage data and take a look at how Dimensional Insight customers are using our technology to help with their response. We won't be using any customer names in our presentation today, given the immediacy of the issue and the long approval times for name usage, but all of the examples here are based on our real work with customers over the last several weeks. There will be time for Q&A at the end, so please feel free to type any questions you have into the questions box, and we will do our best to address it at the end of the webinar. We will also be doing a raffle for a $100 Amazon gift card at the end of the presentation, and you must be present to win, so please stick around for that. Our panelists today are busy working with our customers on reacting to the COVID-19 pandemic. They are George Deely, Vice President of Healthcare Solutions, Nora Lissy, Director of Healthcare, Matt Gorman, Senior Consultant, and Jeannie DeGroot, Senior Consultant. Let's get right into it. Our first topic is capacity management. Hospitals need to understand utilization of the space they have and the number of patients in their facility. Matt, could you please start us off by talking about what you're seeing hospitals do in this area?
Thank you, Kathy, and welcome everyone. Early on in the COVID process, around mid-March, we started polling our customers to see what they were doing regarding dashboards and reporting in response to the COVID-19 situation. We found that some were already well down the road in creating reports, and others were looking for advice from us on what to do. I've been asked to show you the dashboards we created for one of these customers. This particular customer was interested in tracking the flow of COVID-suspected patients through the hospital system, monitoring the usage of their resources, and responding to government reporting requirements that had been thrust upon them. Just a warning, this particular customer is from Puerto Rico, so you may see some Spanish terms on the slides. We've been working with this customer over the past 3 weeks and have gone through 4 iterations of the dashboards as they have adapted their internal processes to cope with the pandemic. The first thing we needed to do was to come to an agreement on the business rules and measures that we'd use to track the patients and the resources. This process also went through a number of iterations. Currently, we have definitions for case classification, hospital area classification, and COVID testing. In terms of the cases, a patient will go through different stages. As they come into the ED and go through triage, they may be flagged as a COVID-19 suspect, and or they may be, an order may be written for COVID-19 test. Once either of these happens, they become a COVID-19 suspect. Depending on their symptoms, they may be just discharged right from the ED, in which case they'll be classified as a COVID-19 low case. Or they may be admitted and become a COVID-19 inpatient suspect. For admitted patients, as the test results come in, their classifications will change. If they never receive a positive result on a test, they'll be classified as COVID-19 negative. Once they receive a positive result, they'll either be classified as COVID-19 moderate or COVID-19 severe. The severe classification indicates that they also had a ventilation order written for their account. And then finally, with good care, most of the patients will reach the COVID-19 recovered status. We'll talk about that a little later on. Also, all COVID-19 suspects admitted to the hospital may receive an additional classification, which is COVID-19 at risk. These are patients who are either age 65 or over, whose EMPI shows a history of COPD, pneumonia, heart failure, diabetes, liver or renal disease, or whose account has had respiratory orders documented against them. And so they watch this pool of cases closely. The hospital broke the hospital into 4 different sections to deal with the COVID patients. In the ED, they have what they call their cohorte section, where there's 23 beds, and those are for COVID-19 suspects that are in the ED. There's 3 beds in the ED for COVID-19 suspects who have a positive result and are waiting for an inpatient bed. In the inpatient area of the hospital, there's 37 beds for the admitted suspects who are waiting for test results, and then there's 11 negative pressure beds for the admitted cases that have tested positive. In regards to the testing, the hospital has 2 types of tests. They have outside tests and rapid tests. The outside tests are sent to an outside lab, and they can take up to 7 days to get a result back, but these tests are more reliable. The rapid tests are resulted right in the hospital in about 15 minutes, but they're less reliable. When a patient first comes into the ED, they usually receive an order for both the rapid and outside tests. A positive result on either test will move the patient to the positive category. Once positive, they need to have 2 consecutive outside negative tests to become COVID-19 recovered. So they only use the outside test to determine when you've recovered. The test orders show up in their EMR order module. The rapid test results are in their ER lab module, and the outside results are entered manually into their EMR HIM module. Next slide, please, George. So once we nailed down all these classifications, we started to put together their dashboards. The first dashboard we're going to show you is what we call the current dashboard. This dashboard refreshes hourly, and it lets the hospital see the current state of the COVID population in their hospital and the current resource utilization for these patients. Starting in the upper left-hand corner, the COVID-19 in-house section tracks the positive cases and the suspect cases that are currently admitted to the hospital or are in the ED. For the positive cases, it's broken down between the severe and the moderate. They can click on any of these numbers and get a detailed list of the patients, the actual patients that make up these numbers. Below the in-hospital section is the at-risk section, and this is just a breakdown of the positive patients that are at risk. And as I said, they'd like to track this section carefully. Below that is a section on in-house testing, and so it shows the current test results of all patients that are currently admitted to the hospital. In the next column to the right, the top section is positive cases, and it shows them what has changed today in terms of their current positive cases. So how has the positive case count changed today? Below that, there's an alert section that alerts them on any cases that need some action. So things like a positive patient that is not in an isolated or cohorte bed, patients that are waiting for test results, and we have certain parameters set up where a rapid test that isn't resulted within 4 hours, or an outside test that isn't resulted in 7 days will show up as an alert. So this section shows them patients that they need to react to. The next section to the right of on the current dashboard shows resource utilization. And this includes the negative pressure beds, the IP cohorte beds, the ED cohorte beds, and the current status of their available ventilators. And we're using the EMR orders to track ventilator usage. And then the final chart on the right shows the COVID-19 positive cases that are currently in the hospital by the patient's city. So they know where the positive cases are coming from. Next slide, please, George. This is the monthly dashboard. This dashboard refreshes once a day in the morning, and it shows a flow. It's a monthly view by day of a flow of the COVID patients in and out of the hospital. The measures are organized by the day in which the case originally arrived in the ED. It shows those that were suspected to have COVID-19. Next, it shows how many were sent home, what they call the low patients, and that depends on the symptoms, and how many were admitted. Of the admitted patients, it shows how many tested negative for COVID, how many tested positive, and how many are still awaiting results. As you can see, a little under 25% of the admitted suspects are currently testing positive for the COVID-19 at this hospital. Finally, it shows how many have been discharged. The next section deals with those testing positive. First, it gives a breakdown between moderate and severe. Those are the patients on the ventilators. The positive patients at risk. It shows the recovered patients, and then it gives a breakdown of where they are. How many are still in the hospital, how many have died, and how many were discharged alive. The last section deals with the testing of these patients as well. And then to the right, there's two graphs, and again, it's a breakdown by city. The first one shows all the new suspects that came in and what city they were in, and then the second one is just limited to those suspects that tested positive and what their city was. Okay, next slide, please, George. Okay, the trend slide on the left is a list of all the measures that are on the monthly dashboard. All the columns are on the monthly dashboard, and the hospital can select the measure, and then the two charts to the right of that will refresh for that measure. The top chart shows the daily totals for the selected measure, and the bottom chart shows a daily cumulative total, which is kind of like the curve chart you'll probably see on the TV a lot. As we can see here, it looks like their new arrival suspects are starting to flatten out. The curve for them is starting to flatten out. The next dashboard, George, if you could go to the next slide. Did you go forward, George? Okay, the next slide is the executive dashboard. This gives the executives a graphical representation of the utilization of 4 sections of their hospital. This includes total bed utilization. So these are all beds, not just the ones for COVID patients. As you can see, they're currently at about 40% of capacity, which is pretty low for this hospital. The negative pressure rooms, which is where the positive inpatients go, are currently at 85%. That will start to alert at 90%. And then bottom left is the IP cohorte rooms, and these are for the suspects that have been admitted to the hospital or waiting for results. As we can see, there's 27 patients currently in that mode, and since we're noticing that about 25% of them are testing positive, it looks like the negative, they should be moved to negative pressure rooms once they test positive, so it looks like there's going to be a crunch on the negative pressure rooms. And then in the bottom right is the ED cohorte rooms, and these are for people in the ED that are suspected of COVID and are waiting for results. Okay, next slide, George. And finally, they are required to report daily to the state a number of measures around the COVID patients. So the hospital sends these daily measures, and it includes the measures track things like suspects and positive cases currently in the hospital, those with respiratory issues, ICU utilization, ventilator utilization, bed utilization by service line, and patient with COVID-19, patients that tested positive for COVID-19 that have died. And like I said, the hospital sends these numbers to the state every day at 8 a.m. So this is the set of dashboards we've put together. As I mentioned, it's been an iterative process. We've gone through 4 different iterations, and basically the hospital used the initial dashboard to help them re-engineer the processes and how they wanted to break up the hospital and divide the sections. But it looks like we're getting pretty stable now, and it looks like iteration 4 may be the one they use going forward. Back to you, Kathy.
Thanks, Matt. Another area that hospitals need to deal with right now is the cancellation of elective procedures and office visits and how that's affecting staffing and revenue. George, could you talk about that?
Yes. So the recently paired Federal CARES Act provides a variety of different forms of relief through multiple programs, including the Provider Relief Program through the Department of Health and Human Services, the Payroll Production Program, Payroll Protection Program, and then the normal FEMA disaster relief. So here's a few examples of what's covered, and this is taken from FAQ document about the CARES Act. So increased staffing and training, personal protective equipment, building out new existing ICUs, temporary structures, and then foregone revenue from canceled procedures, and then routine ambulatory office visits. So we're going to talk about two of these that we have a direct experience with. But first is some of the preface to that. Pretty much as expected, this is going to be a very administratively intensive process. So this is part of the terms. This is an excerpt from the terms and conditions document that you would need to sign off on in order to be eligible for the first tranche of relief payments as a healthcare provider. So just to point out some of the highlights here. So no later than 10 days after the end of each calendar quarter, you need to submit reports, and they need to be fairly detailed. So just kind of a few insights and observations as to what those reports are going to need to include. So total amount of funds received, and then how those funds were expended or obligated for each project or activity, with a detailed list of projects for at least the large sections of the funding. So name, description, project activity, and then obviously the amount of money spent, including the estimated number of jobs created or retained. So this is an area where we think that decision support in general, but in particular analytics, data management, and business intelligence technologies are going to be very, very important. So one of the areas that our customers have asked us to help with is trying to estimate the impact of service volume reductions. And looking at a combination of hospital and ambulatory data, we're trying to get some insight into canceled elective procedures, as well as the routine ambulatory office visits that just aren't happening now. The impact of no-shows maybe on the early stages of the pandemic, and then the logistics around rescheduling and appointment backlogs are going to result once things get back to normal. Then we have the impact of telehealth encounters. So here's an example of some trend charts that we've put together that are beginning to show the impact on ambulatory visits. So we can see that in March, the trend towards office visits is going down, a big corresponding increase in canceled appointments, some no-shows, but less than had ordinarily been the case because there are fewer visits. And then we see the emergence of telehealth visits in March, and these trends will continue to play out. Suffice it to say that there's lots of detailed information underneath these summarized visualizations, but this begins to tell the story. So Nora, you have extensive experience as a nurse manager, and operations manager. Maybe you can talk a little bit about the human capital impact.
Sure, thank you, George. In this particular instance, we're looking at and speaking with some of the customers and the required documentation necessary for reimbursement on basically the payroll side of things, is being able to take in your time and attendance and the payroll information, getting historical trends so you know what the norm is, and then obviously the whether there's flags you've created in your time and attendance system, or there's someplace else where you're tracking people that were specifically brought in or trained for COVID, but also just looking at the trends of, and some of the guidelines that FEMA puts out, or even the government puts out when reimbursement comes into play is, well, anything that's considered normal activity during this time will not be reimbursed. Makes sense. But in that time frame, how do you determine what we want to say is normal, but being able to bring in your historical time and attendance, compare it to the period of time where COVID was in place. How many people actually were either furloughed or put out or asked to use their PTO because things aren't happening? How do you reimburse those people? How do those people get recovery? As well as, or those nurse managers or directors that were taken from their management role and put into a patient care role because of the volume of patients coming through. So having access to your payroll systems in such a way that you can quickly assemble these reports and get them ready to go off to FEMA and the government is really what's critical here. And we've done that where we've done pretty well with being able to pull in all various different kinds of times and attendance. And here's an example of one of the graphics. This is our older technology where you look at it, but you can see where we can pick a pay period or visualize even a pay date and look at information by way of job class, employee, department, GL department, and various other ways by way of the pay codes, looking at overtime, callback, utilization of sick time, utilization of some of your other pass-through codes that you might have for that are related to COVID. So we had that capability to pull that in as well. And then just from the telehealth encounters piece, where CMS right now has kind of loosened up the rules on care and reimbursement for telehealth because of the fact that we really don't want to be too close to each other. So they've kind of loosened up the fact that, you know, if a physician is doing a telehealth visit, it doesn't necessarily have to be a face-to-face, you know, a visual to visual. It could be that they're talking on the phone and having a consult with the patient. That could be charged as a telehealth visit based on the rules right now that are because of the COVID-19 process. So, so those are some of the things that we can bring into play when we're looking at that, what's considered a telehealth visit.
Great. Thank you, Nora. Thank you, George. Many healthcare providers have noticed patterns in COVID-19 infections. Jeannie, could you talk to us about how they're visualizing some of those patterns to get a better handle on them?
Sure. So beyond the tracking of the tests and the results using graphs and dashboards and detailed lists, one of our customers is actually visualizing the spread of COVID using maps. So one of our first attempts when we started looking at graphing this out on the map was to show the boundaries of zip codes and color coding them with the number of patients with positive results. But that didn't really show the spread. So our next step was to plot on the map the points for every patient by their address. And that again gave us a nice cluster and visualization, but it was very cloudy and just too cluttered. But it does show the spread and everything. So then the next thing that we did was they have an epidemiologist going through and clustering the different cases. And so now what we're doing is we're layering the clusters on a map to show how the spread is going. And it's been very interesting. So we have actually, this is just showing two, but we actually have about 30 clusters that we're tracking right now. So that's been the most interesting. So then with the graphing technology, the mapping technology, we can zoom into one dot or one area of the map and get to a closer view of that section. And then also with the power of the technology is to get to the detail. So clicking on that point brings us up a list of patients. Back to you, Kathy.
Great. Thank you, Jeannie. Now, our final topic of the day before we get to your questions. Once COVID-19 patients have been treated, hospitals need to track and analyze their cases. George, how are they doing so?
So one thing that the folks on the webinar might be familiar with, or possibly not, are the coding guidelines that have been issued by the Centers for Disease Control. There was an initial version of this document that came out in early March, and then it was revised recently within about the last 2 weeks or so. And this provides guidance in terms of how COVID-19 related encounters need to be coded. And something that was somewhat unprecedented, I believe, at least in terms of a quick turnaround, was the introduction of a new ICD-10 CM code specifically for COVID-19. You can see that that is U07.1, and that's going to be used to code confirmed COVID-19 cases. But there are a variety of other stipulations from this document, including various comorbidities around pneumonia, bronchitis, acute respiratory distress syndrome, and then coding guidance around suspected, confirmed, and rule out cases. So this is going to be very important from a reimbursement perspective, as well as for future research and analysis to try to understand the patterns of what happened during the pandemic. So we actually use this information to produce a package of measurements. One other thing I wanted to point out was the fact that there were quite a few stakeholders that had to come together to agree on this guidance. So once it became official, I believe it means that everyone from CMS to the National Center for Health Statistics, the trade group for coding, AHIMA, and the American Hospital Association are all on the same page on this. And at least in theory, it's supposed to last from April 1st to September 30th, and we'll hope that that's the case. But what we're doing in order to help Dimensional Insight existing customers is to create a package with the measures or key performance indicators that are derived from that CDC guidance. This does require that the existing hospital operations application be licensed. But this is just to give you an idea as to what decision support technology can provide in terms of visibility into this type of information. So the package consists of 24 measures or KPIs, an additional 20 underlying rules that specify business and clinical logic, some value set entries, we call them flag tables, the introduction of the new code, which also maps to the HRQ diagnosis clinical classification of viral infection, and then a set of dashboard pages that are really just considered to be a starting point. Because as Matt mentioned, various organizations are going to want to do different things with their data. This is intended to be customer installable with a set of instructions, and we're planning to release in a couple of days by the end of the week. Just to give you an idea, and this is really for both for Dimensional Insight customers as well as other folks, as to the types of measures that can be derived from this information. So we came up with, these are 24 measures that capture the concepts within the guidance document from a few different perspectives, from discharges and non-inpatient activity to activity in the ED to various outcomes measures such as length of stay, mortality, and mortality rate. And each of those actually has the documentation derived from the guidance document embedded in the measure. The metadata is actually part of the measurement. So when you're doing analysis on it, you can bring up information here that shows you both a narrative description of what the measure is intended to represent, as well as the actual activity of what's going on behind the measure. So we've talked about a variety of things during the webinar today, and to give you some insight as to where some of this information came from, we're providing as part of the webinar slides and on the replay where you can actually get to this information. So we've got the coding guidelines document that I just mentioned. Here are several URLs that point towards information on the CARES Act and specifically the Provider Relief Fund. I pointed out some of the terms and conditions. Those are in this document here. And then on the CMS side of things, the Accelerated Advance Payment Program, which provides the opportunity to get reimbursement in advance of services actually being provided, is here. Back to you, Kathy.
Great. Thank you, George. And thank you to our panelists. We'll be opening it up to questions in just a moment. So if you have something you'd like to ask, now is the time to type your question into the questions box in your GoToWebinar panel. While you're doing that, let me tell you a little bit about Dimensional Insight. We help our customers keep complex problems simple with our industry-leading analytics platform, Diver platform. Diver has been named best in class in healthcare business intelligence and analytics by KLAS Research for 7 out of the 10 years that KLAS has offered the award. Unlike many analytics vendors, we have healthcare domain expertise, as you've seen on display today. We have the experience to guide you to successful outcomes, and we will help you innovate quickly to solve your most pressing challenges. If you'd like to get in touch, please call us at 781-229-9111, email us at info@dimmins.com, or visit our website at healthcare.dimmins.com. Now on to some questions, and then afterwards we will do our raffle. So our first question for our panelists, are there any examples you have of hospitals that are using analytics to manage materials such as PPE?
I can answer that question. Yes, we do have one of our hospitals out in California that I know specifically. When they opened up, they had they built some tents for people coming in for the rapid test outside, and they also they pull in their materials management info, knowing what's on hand, when's the next order date, when's the next receive date, and basically follow that through, and that refreshes. I believe he said he was actually refreshing that a couple of times a day to make sure they stayed on top of their equipment, their PPE specifically.
Great. And did you provide a method for sending the required government reporting directly to the health agency?
No, we weren't asked to do that. I think, there's only a small number of measures. I'm not sure how they do that, if they're just putting them in a spreadsheet and sending them daily, but we weren't asked to get involved in actually sending the measures out.
I can speak for several of these states in the U.S. Our customers are using Dimensional Insight technology to produce the required government reported information, but I'm not aware of any automatic electronic transmission yet.
Next question, what types of data are you using to assist the clinical team with early detection of patients with COVID-19?
I'm not sure I understand the question. At this point, we're taking in basically from their order information and their testing results, and again combining it with their history to show that these are people at risk. But I don't know that anything else. Matt, you haven't done any more on that front, have you?
No, I haven't. And like I said, basically it's a decision made in triage as to whether they're going to be a suspect or not. Once they're a suspect, they order the test, and the rapid test comes back in 15 minutes, and that's the one that they use to classify them as positive or not. So we're just relying on the test results in that situation. As you said, once they start to flag people as suspects, then we enhance the data by we look at the medical history of the patient to find out if there's anything else they may be at risk for. And then we also track orders for respiratory orders which may also put them at additional risk.
Next question, are your teams using any resources to stay on top of the most current data that's becoming available from the field for best clinical or operational practice?
I think we probably are seeing that reflected in the dashboards. As I said, we're on iteration 4 now of the dashboards at this one particular hospital, and I think that's because they are responding to best practices that may come out as people learn more about the virus and its impact on a hospital system. I know they've had 3 different configurations. I showed how there's 4 units in the hospital now that they're specified. we've gone through 3 different configurations of how they wanted to organize the hospital. And again, I think they are responding to updated data, and it gets reflected in how in the measures that they ask us to create for them.
Another answer to that question would be other webinars just like this. There's quite a few examples of organizations sharing as they learn, so we're trying to take advantage of as many of those as possible. We're based in the Boston area, so we've been participating in the Massachusetts Hospital Association webinar series, which is very good.
And someone asks, they say they missed the first few minutes, so if you could tell them, where is this data stored for analytics?
Our application extracts information directly out of their EMR. In the case of the current dashboard, there's an extract that runs once an hour, and then the monthly dashboard is refreshed daily. We pull that information into a column or database. We call it a C-base, which is our technology. And then all of the dashboards and the reports that you see report from the column or database that we've created. George, I don't know if you want to add to that.
Yeah, there's another interesting aspect to our approach, and that's the measures that both Matt showed in terms of the active case tracking and the post-discharge ICD-10-based measures that I discussed. Those are programmed into our applications using a technology that we refer to as the measure factory. So we're able to very quickly specify and construct these measures, and then get the information beneath the measures out to decision makers via automated reporting and interactive dashboards and self-service dashboards where folks on the front lines can specify both which measures that they want to use, as well as a visualization that is best suited to what they're trying to do with the information.
Next question, are any of your customers, specifically community health centers if possible, using analytics to mitigate losses in quality measure performance while transitioning to telehealth from outpatient visits?
I'd say we haven't gotten there yet. We haven't had any requests to look into that yet. I do believe that that's going to come about, but that has not started yet. People haven't asked us to help them to look into that at this point.
Next question is a 2-part question, has a question and then a follow-up. So do you have examples of dashboards created by or data being used by outpatient radiology companies? And then the follow-up is, if not, then what kind of data, in your opinion, would be useful to have represented as a dashboard for outpatient radiology?
Are you talking, if this is specific to COVID? I don't know that I've had anybody call us from a radiology department, but we do have some radiology centers that use our technology for their information in their radiology centers. We have a very large center out in Arizona that uses our tool to manage their everyday radiology center and the comings and goings and operations. If that answers the question, I'm not sure.
And then a last question for today. Our hospital is working on a system to push new data out to leaders and staff on best practices. Any thoughts on platforms to best do this?
Kathy, could you repeat that? I missed the last part of the question.
Sure. Our hospital is working on a system to push new data out to leaders and staff on best practices. Any thoughts on platforms to best do this?
Yeah, certainly we think Dimensional Insight would be a good choice, but we'll talk specifically about the reason why. Matt mentioned the number of iterations in the example that he discussed, and I think that's that's pretty characteristic of what we're seeing. The best practices are evolving very quickly, literally day to day, in some cases hour to hour. And I think the advantage of using decision support technology is that it's designed to respond to requirements that evolve very, very quickly, where EHRs, for example, tend to be a little bit more stable in terms of how they're configured to support workflows, whereas with information, as soon as you know something, you're going to want to know something else. So the ability to respond very quickly as those best practices emerge, and then provide the information necessary to make the decisions around those best practices. So, the flexibility, for example, to implement a new KPI that you've just realized that you need, but also in addition to being able to visualize, the trends and the dynamics behind that information, very quickly get to the underlying information and analyze it, whether that's an individual patient or maybe a trend in the infection patterns.
Another piece to that, one part of our technology is, as George had mentioned, sometimes the EMR is set up, and an instance like this, you might not have. Hospitals are really good at responding to emergencies, and we do whatever we can to get the work done, and then we come out the other side and go, uh-oh, now we have to document that, or they go into an Excel spreadsheet mode or write it on paper. Our technology has the capability where we could create something in the portal for you that kind of would mimic your Excel spreadsheet, but you go into this portal that now becomes part of a data set that you can use with your analytics. So now you're not having to copy Excel spreadsheets, save them, put them out there. You could just come right to the portal, save it, and that could be built to give you instant return on your results. So you can push the button and set it, and it can update your graphics and do what you need with it. So that's another part of our technology that allows for the quick and rapid change of environment and rules, if you will.
Another thing that I've seen a lot of our customers do is that not only will they use our tool to track adherence to best practices, but then they'll compare that to cases where the best practices were not used, and so that they can show results and improved results to help reinforce these best practices. I see a number of our customers using the tool to do that.
Great, thank you.
I'll add one more thing, a point that Nora has made is that right now we're dealing with the patient and the health side of the pandemic, but once that begins to subside, the burden is going to shift to the administrative side of things, applying for reimbursement and relief, as well as substantiating those applications. So we don't know exactly what that looks like yet, but we're beginning to get a better idea, and it is going to be very, very intensive. You can imagine the folks in accounting and finance towards the end of June into early July trying to prepare those reports that are going to be necessary to justify reimbursement.
Great, thank you. Thank you to all of our panelists. Thanks to all of you for joining. Before we sign off, we will choose our winner for the $100 Amazon gift card raffle. Today's winner is Michelle Stosky. Michelle, I will be in touch about your award. We do have a short 3-question survey that will launch in your web browser after you log out. I'd appreciate if you took a moment to fill it out. Thank you all for joining us today.
Thank you, everyone.
Take care.
Bye-bye.